Hello, I'm Douglas DiRuggiero. I'm a physician assistant who practices dermatology in Georgia, and it's my honor to welcome you to Grand Rounds in Atopic Dermatitis. I get to share a case of mine with a colleague and a friend and someone I respect tremendously, and that's Dr. Peter Lio.
Well, thank you so much for having me. I'm Peter Lio. I'm a clinical assistant professor of dermatology and pediatrics at Northwestern University in Chicago, Illinois.
Well, for the next several minutes, Dr. Leo, I want to discuss a case that I think will allow us to kind of really share back and forth a scenario that I think a lot of our listeners probably deal with on a regular basis in their clinic. This is a 38-year-old man who comes in. Now, he's had lifelong atopic dermatitis, worse when he was a child. Then he had a period of time when it got better. Now it seems to be getting worse again in his 30s. The rash has been present and increasing over the last 6 months, right? He's been on topical corticosteroids multiple times throughout his life, the majority of his life, to be honest with you. But he stopped it 4 months ago. He says his itch is like an 8 out of 10. So that's pretty significant. I mean, that's life altering, right? He wakes up at night, it impairs his ability to work. He feels like people are constantly looking at him as coworkers because he's scratching himself all the time. He's got, fears of continuing with steroids. This is a scenario that I see on a pretty frequent basis. This is a scenario where I think social media has kind of helped us in medicine in many ways. It's easy for us to downplay that social media could be giving misinformation, but I think social media has done a good job of I have patients come in and say, I don't want a steroid written for me anymore, or I've heard about the dangers of them. I think we need to level set that a little bit because steroids have a lot of utility. They're not to be thrown underneath the bus, but at the same time, I think it's good for patients who have that steroid phobia, so to speak, to say, well, I'm glad you've mentioned that. And the steroids are very helpful when they're used properly. But in this case, you've used them for many, many years. I've got good news for you. We have several other fantastic steroid options that are there. Are you seeing patients like this as well?
Every day, honest to goodness, this is a very common scenario where these are not patients who will not comply. These are not patients who have not tried steroids. These are patients who, in many cases, have really kind of overused and abused steroids.
Mhm.
And it is a big deal for these patients. And I think they've kind of come to the conclusion that this is not the right path. So I think both of us are pretty sympathetic with them. We're not telling these patients that they just have to keep using more of it because they've already shown us that using too much has not even gotten them where they need to be.
Exactly. And, so as we continue this case, this is like identified plaques, and the folds of the arms, the back of the knees, kind of a classic presentation. And we see excoriations around the neck, right? Fissuring and around the hands, some pretty significant hand dermatitis that this patient had as well. I put his BSA between 15 and 18%, which is a pretty significant amount. Several areas, if I were going to do an IGA, which I don't always do in the office, but I would say if I was looking at some of the lichenified and fissured areas, that certainly would be an IGA of 3, and some areas maybe even a 4. Not that overall they all were, but what I'm basically saying is that this patient was pretty significant. I did not do an ADCT score on this patient, but I think if I had, he would certainly be over 7, which is what we're saying is not controlled in terms of looking at that particular tool.
I agree. And I will say a case like this is somebody that I would immediately think about. First, do we need to do something that is outside of topicals? Like in the old days, before we had non-steroidal alternatives, you'd almost have to say we're going to go to a systemic. But now I feel like for somebody who wants to be steroid free and still wants to stay topical, we finally have some amazing options. So it's been so cool. Just in our career, we've seen that literally turn from essentially zero because tacrolimus and pimecrolimus were the first non-steroidals that were
Mhm.
approved. That was the year 2000 and 2001. So we saw
Mhm.
those come out, and now we have a whole host of really good potential options.
I know it took us a long time to get something something new. That seems like in medicine, the way things move so quickly in terms of having a steroid-free option from 2000, 2001, all the way up into the 2020s. It was a long time for us to wait for something, but I think it was worth the wait. So I talked to this patient about having a steroid-free cream and on the prescribing side, this is a cream, topical ruxolitinib, that per label is supposed to be used at 20% body surface area and below. And I think that he certainly fit that category. But I have no problems using all the way up to that amount. I mean, that's 20 palms and that's, I think historically, I would have always thought immediately try to get them onto a systemic. Do what you have to do, step through therapies, whatever you have to do to do that. But now I have a cream that I feel like is so powerful in my hands that I am looking at higher BSAs, within indication, with this topical ruxolitinib cream. And I said, let's give this a try. He wanted to. He was eager to have something that was going to kind of address his immune system and the inflammatory response in a different way than steroids do. Didn't have the cutaneous side effects that I expect to see, with long-term steroid use. And so I said, look, you use this twice a day. You can still use your daily emollients with it. Went through the regimen, make sure he was doing all the right things, with his cleansing. I also talked to my patients too about some, are you on probiotics? Are you taking vitamin D? Or doing some other things that we know is good for the skin? But for him, felt like he was doing a lot of those things already. And I said, well, good. This will be a good case for me to see myself how this cream can make a difference. Are you using it in that, or do you view that these steroid cream options as something just for very small amounts of BSA?
No, I'm with you. Up until 20%, I feel comfortable. And I'll also say, honestly, if someone has more than 20% body surface area, I'm still okay using it. I just ask the patient to limit the use of the product to 20%. So just because you have 24% doesn't mean you can't use it. I would just say, why don't we pick these trouble spots right now? We'll just do our hands and arms, and we don't want to put it all over because I don't want them to have any issues with that. But you still can use it in those patients, just more selected areas.
Yeah, so I mean, I did a 2-week follow-up. That's kind of a standard thing for me with using this particular topical. Itch improved significantly from that 8 or 9 out of 10 down to a 2 or 3, right? Sleeping better at night. In fact, he reported that his itch was better really within the first 24 hours. And I see that this cream in particular is just so fast at relieving itch. I've even had some patients, I put it on, and then they tell me by the time they got home, they could feel a difference, and you can say, well, maybe a steroid cream does that too, but they actually tell me that it feels different. It doesn't feel like it's just itching a little bit less or that it's been moisturized well. It actually feels like that the deep down where the itch sits, they feel like is what is being modified in a very quick fashion. So 2 weeks later, week 4, right? I said, you're looking great at 2 weeks. I said, I want to see you back in another month, but give me a call in a couple weeks and let's see how you're doing. So they'll call back at week 4, getting better, less scratching, less itching. My skin looks better, and he's still using all the areas. Some areas improved within the first week. Other areas are a little more stubborn. He's still using it. So the BSA is shrinking down and he's using it just on those targeted areas. So by the time I see him a month after that first visit, his IgA I would put down to a 1, a 0 in some areas, a 1 in others. That BSA of 15 to 18% is down to only between 2 and 4%. So significant improvement that you would have there. I don't really calculate a lot of easy scores in the office. I do that more and view that as something that they would do in trials. But I would certainly say that he had a 75 to 90% improvement overall in his presentation from the beginning to the end. And high patient satisfaction. I mean, it's really nice to see that, yes, I am a strong and heavy writer of all of the biologics and the orals and the systemics. I believe in them, but there's a good number of patients now that I'm not just postponing the trip to that, but I'm actually altering the course and saying maybe we don't need to use those because I think these medications are actually modifying the disease at that cellular cutaneous level. So I think we're seeing disease modifiers in topical treatments now, which I never thought we would see.
It's remarkable. One of the early data points I saw that was published a few years ago now, but was showing that you could measure clinically meaningful itch improvement in 15 minutes after application of topical ruxolitinib. That was pretty cool to see something working that fast, but also something that we know can be used for a longer period of non-continuous use. We can use it chronically. Ideally, we'll take little breaks as the patient has improvements, but they can continuously use it for up to, I usually say 8 weeks or so, and then take little breaks, but over time they can go back to it as they need it without having to worry about steroids. It has really freed, I think it's freed our entire profession up from some of the limitations of one class that has been dominating for so many years. Now we actually have some real choice for patients.
Hmm. Well said. Well, thank you for joining us for this grand rounds in atopic dermatitis. Dr. Lio, it's always a pleasure being able to share the screen, share the podium, share any time with you. I appreciate you so much.
Likewise, my friend. Thank you.